I take clap back down. Good talk. He's a smoke break.
No.
Oh,
You get that in 2 hours.
2 hours.
Yes.
Oh, Chuck's
Oh. You didn't tell me that. That one in the middle.
You got your 6 Mountain Dews, you're good, buddy.
Yes, 4. So we made some protocol books yesterday. It's not full protocol books. It's just the protocols that are done. It's just the protocols that are done. And so they, not all the protocols are in there. All policies and procedures are not in there either.
She's talking.
So if you're looking through and you're like, why aren't they all in here? It's just those that are done. We had all of our protocols done, and then the state sent out their updates in October, which they're going to be doing every year. And tell her just to come here.
Okay, she said just come inside. When you walk in the door, take a left and follow it all the way to the.
And so every year there may be some minor updates. This year there were 53 protocols that had updates on them, but it was minor things. It was typos. It was changing the SBO2 to 92%. It wasn't anything major. All the major changes came last year. And so I'm still in the process of working through all the minor changes on those. They're almost done, but what you have is what is done. So with them, they've all been renumbered, color-coded, and organized, and they are in the order that the state has them in because we cannot deviate from that. They're the colors that the state has, the numbers, the titles, everything that the state has because we have to follow that. We don't necessarily agree with the order of all of them, but it's how the state has them, so we have to follow that. All policies and procedures have been updated to match the protocols, and we've standardized the doses and the routes for all meds throughout the protocols. And this is the order that they are in the book: universal, airway, respiratory, adult cardiac, adult medical, adult OB, trauma and burn, pediatric cardiac, pediatric medical, toxin environmental, scene operations, special circumstances, community paramedic, and then your destination plans, your policies or procedures. And out beside it are the colors that correspond with them and then what they're called. So it'll be UP1, UP2, such as that. Pediatrics, anyone that fits on a link-based tape will be considered a pediatric. Before it was like 11 years old, 12 years old, 15 years old, depending on which protocol you looked at. So everything now is simply, if they fit on a link-based tape, they're pediatric. If they are larger than that, we treat them as an adult. However, still, if they are under the age 18, they go to the pediatric ED. Okay, it's just for treatment purposes only. If a protocol says to consider something, then that is all it means, to consider. Okay, it does not mean that you have to do what that treatment is. Okay, consider it, think about it. It may or may not be helpful, just things that you can think about. All the protocols, normal saline changed to crystalloid solution, and that is because eventually we're going to be changing to LR or adding LR, and so that way it doesn't matter. They're both covered under that. She just called me and we told her just to come on in, so she'll be signing in just a minute. Pay close attention to the doses. Some protocols have adult and pediatric doses in them, and then some we were able to separate. Your UP1, Universal Patient Care, on the back of it, the state put capacity. And what means capacity as far as patient refusals. And this is something that Dr. Wells and I have been talking about for quite some time, and we weren't really sure how to define it and word it so that we could use it for our refusals. So the state did a really good job of doing it for us, so we didn't have to. This will be in the refusal policy. It is being updated also. So this will be in the refusal policy. Also, with the new refusal policy, all refusals must be written by a paramedic. Not well and uninjured, but refusals must be written by the paramedic on the truck. Okay. So patient refusal is a high-risk situation. Guys, these are really high risk. They are your highest liability calls. And so we really have to do everything right on them. So encourage the patient to accept transport, right? Encourage them to allow an assessment, including vital signs, and then making sure that we're documenting everything, including the mental status, vitals, and their capacity to refuse care. All right, so the guide to assessing capacity. 1, they should be able to communicate a clear choice. All right, so that means they should remain stable over time, inability to communicate a choice or the inability to express the choice consistently demonstrates incapacity. And if that's the case, then they cannot refuse. Okay? Relevant information is understood. They should be able to display a factual understanding of the illness, the options, and the risk and benefits. Okay, so they should be able to relay back to you what the risks are if they don't go to the hospital. And when we explain risk, we need to make sure that we explain risk of permanent disability and death. Not just death, but also that there's that permanent risk of, or risk of permanent disability. Appreciation of the situation. So the ability to communicate an understanding of the facts of the situation. They should be able to recognize the significance of the outcome potentially from their decision. Again, they need to relay that back to you that they understand what the outcome could be. And then manipulation of information in a rational manner. They should be able to demonstrate a rational process to come to a decision. They should be able to describe the logic they're using to come to that decision, although you may not agree with their decision, right? We're not going to always agree with them. However, they're able to make sense. It's rational. We have to let them do that, okay? Yes.
And all of the bottom, it applies to like if a person is the power of attorney of the patient. So we express those to the person that's the power of attorney that's for medical power of attorney. For
Yeah,
the patient.
anyone who is refusing, they have to be able to demonstrate all those things.
Because the patient may not be able to, but they need. Okay.
Correct. Yes. So making sure also whenever we're determining if a patient is conscious or oriented times 4, right? Those 4 things are what? Person, place, time, and event. So where in those 4 things does how many quarters equal $1 fall?
Where did that come from?
That's what I would love to know. Stop doing it. That is not one of the things that we determine when we're determining if a patient is CAO times 4. It's not part of it. So whoever taught you that, don't listen to them anymore. Okay, stop doing it because it's not pertinent. UP3, abdominal pain, vomiting, diarrhea. They combine these 2 protocols together. It is for adults and for peds, making sure that if we're going to give Zofran, that we do a 12 lead to confirm that the QTC is less than 450. Because if it is greater than 450, we do not want to give Zofran. Why?
They can go into
Go into torsades. All right, so if Zofran is contraindicated for whatever reason, they're allergic to it, they can't take it, QTC is too big, whatever, then you can have them attempt to smell an alcohol swab if they are nauseated. Okay, bust open alcohol swab and have them smell them, and that will help with nausea.
and it's a 12 lead, not a 4 lead.
Correct. UP6 IVIO access. If you look at the back of it, there's lots of really pretty pictures that explain all of these things, what each one is, how they are, and everything else. So Portacath, you guys can access that, you know that following the Portacath access procedure, which is PAS 13. And if you guys, everything just follows right along as far as protocols in the book. Dialysis catheter may only be used in cardiac arrest if unable to obtain IV or IO access. So those of you who have been here as long as I have know that before we were able to access ports or anything else or do IOs, our only option in a cardiac arrest if we couldn't get an IV was to do a dialysis catheter, so a VAS cath. So only if you cannot get any other access can you access that for cardiac arrest. PICC line or central line you can access using PAS 7. When accessing any catheter already in place, make sure that we clean that port really well with alcohol or some other similar disinfectant so that we are not opening them up to more infection. Okay, so clean that really well. Serious signs and symptoms, or if they're unstable, then we want to limit the IV attempts to 3. And if you're unsuccessful, then go to an IO. Fever infection, UP10. Temperature, 100.4. And symptomatic. Okay, so in order to treat fever, it has to be 100.4 and they must be symptomatic. Okay, so just because I have a temp of 101, if I'm hanging out, having fun, and all my vitals are stable, do I need any Tylenol for my fever? No, let your body do its work. Okay, if they're symptomatic, then we want to treat that. We went with the manufacturer's recommendation on dosing. Okay, this is what's been in hand teddy for a couple of years now. So this is what we've been using, but it's now in protocol. And it doesn't fall exactly as 10 mg per kg, 15 mg per kg. It's in the middle of that, but it's really simple so that your dosing is very easy. You're not having to draw up 5.34 milliliters or anything like that, how it used to be. It's really simple and streamlined for this. Fayetteville Fire Department will be adding Tylenol, oral Benadryl, oral glucose, and albuterol. And so if you get on scene and they tell you that they've given Tylenol, just make sure you verify the dose and everything else. But that will be coming. NSAID should not be used in the setting of environmental heat emergencies. Don't give Tylenol to patients with liver disease or liver failure, and please do not give aspirin to someone under the age of 15. Pain control. So we split this up into pain control adult and pain control peds. They're both UP11. There'll be one right behind the other. Okay. So before it was mild and then moderate to severe were your two arms. So we switched that and made it mild to moderate and then severe. And in your mild to moderate, you can give Tylenol 650 or Toradol 15 mg IVIO or 30 IM. So it's 15 or 30. For severe, you can give fentanyl and or ketamine. We changed the fentanyl dosing because 1-for-1 was really hard. So we changed it. If they are 50 to 74 kilos, you're going to get 50 mics. 75 to 99, you're going to get 75 mics. 100 or greater, 100 mics. Really easy. Each subsequent dose will still be 25 mics. Okay? And 100 is the highest dose that we're going to be giving. Please don't give it if their blood pressure is less than 110, right? Because it can cause a decrease in their blood pressure, so we don't want to get it. Ketamine, we changed to where it can be repeated in 20 minutes instead of 30 minutes as needed, and you can give a max of 3 doses now. Vital signs should be done before, 10 minutes after, and at patient handoff anytime we've given pain meds. However, if you're giving pain meds faster than that 10 minutes, making sure that you're getting a set of vitals in between each dose of pain medication. For peds, mild to moderate, you can give Tylenol PO, and then Toradol 0.5 mg per kg, IVIO or IM with a max of 15 IVIO or 30 IM, which is your adult dose. For severe, their fentanyl is still 1 mic per kilo with a max of 50, and you can only repeat it 1 time. So fentanyl in peds can only be repeated 1 time in 5 minutes at half the dose at 0.5 mics per kilo. So that's going to be a max of 25. So a total max would only be 1.5 mics per kilo. For children, determining what their pain score is, you can use Wong-Baker or FLAC. So who can tell me how you do Wong-Baker? Yeah, how do you do a Wong-Baker?
Which one of these do you feel?
Till like he
That's
points
exactly
it.
right.
Exactly right. Good job, Alderson. You show them the faces and ask them which one do you feel. It is not how many people do, and they look at you and say, oh, you look like you have Wong-Baker too because you're just sitting here chilling on a stretcher. That is not how it's done. You physically show them the pictures and ask them where they are on that pain scale. Okay? And then again, making sure you're obtaining your vitals. As far as ketamine in your pain control, for a patient who fits on the link-based tape, you must call direct online medical control and speak to the attending pediatric PIC to get orders if you want to treat with ketamine. Okay? Must be the pediatric PIC. Anytime we're calling to get orders for peds, you must speak to the pediatric PIC, not the adult, because adult ED physicians do not know peds like the peds doctors do. Okay? Appropriate indications, patients who've developed an opioid tolerance or sickle cell patients with an opioid tolerance, patients with obstructive sleep apnea, and you can use it in combination with opioids to limit the total amount of opioids that were given. You can still give your fentanyl loading dose, give your ketamine, and then give your subsequent fentanyl dosing if you need to for severe pain in patients. Use caution, so don't administer rapid IV push. Right, that could be bad for the patient. Avoid inpatients with cardiac disease or uncontrolled hypertension, because what is a side effect of ketamine? Hypertension, good job. So if they're already hypertensive, we don't want to give ketamine to them. And then avoid inpatients with increased intraocular pressure, such as glaucoma. Police custody, people who, we don't want to transport them as long as their arms are handcuffed behind them, right? It's going to prevent us from being able to do an appropriate assessment, and it could lead to injury. And if that patient suddenly becomes unresponsive and we need to do something to them, then we've got to wait for law enforcement to get out their key, to uncuff them, move them around to the front, for us to lay them down and be able to treat them. And so we don't want to cause that delay in care. Maintain a high index of suspicion for underlying medical or traumatic disorder or contributing to behavioral disturbances. So medical causes are going to be more likely in people less than 12 or greater than 40. Okay, so we want to rule out the medical causes before we automatically assume it's a behavioral problem if they've never had a behavioral problem before. Okay, medications are not to be used solely to aid in placing individuals into police custody. Physical and or chemical restraints are reserved for a medical emergency in order to prevent imminent injury to the patient and or providers. Patients exposed to chemical spray can develop respiratory complaints up to 20 minutes after they've been sprayed. So if you respond to someone who's been sprayed, make sure that we stay on scene with them for that amount of time to make sure they don't develop any respiratory complaints, especially if they have asthma, because they're going to be a lot more susceptible to that. And then all patients with decision-making capacity, even though they're in police custody, they still have that right to participate in the decision-making regarding their care, and they can request care or they can refuse care.
So at that point, if they refuse care, who signs? Is it still the patient that signs even though they're in custody?
Yeah, because they're still making their own decisions. Now, unless they're handcuffed behind the back and law enforcement won't move
Just
them
document that
handcuffs,
law enforcement.
then law
can
enforcement
sign.
can sign
Okay.
for them as their guardian, yeah. But if they'll let them sign, then that's the best option, but not always going to be the option.
So this is particular in those cases that law enforcement's like they have to go before they go to jail and the patient doesn't wanna go.
Patient doesn't want to go, I can't force them to go, they have the right to make their own decisions, and you can, obtain a
'Cause I know
refusal,
that's usually a,
and then they can take them on their own, they can drive them over there. We're not going to kidnap the patient. Sorry. Seizure, we split this into adult and ped, so you will have UP13 seizure adult and then seizure pediatric. For adults, you can give Versed 2.5 IVIOIN or 5 IM. For peds, you'll give 0.1 mg per kg, all routes with the max single dose of 2.5. You can repeat that every 3 to 5 minutes as needed with a max total dose of 10 milligrams. Okay, we do not give Versed to prevent additional seizures. It is not a prophylactic medication, so please stop doing that, okay? They must be actively seizing for you to give Versed to them. And do not delay an IM administration. If you can't get IV or IO, then go ahead and give it IM. For suspected stroke, the most important thing we can determine is their last known well time and the time of symptom discovery, right? Because that's the biggest piece of information that they need in the emergency department. So tier 1 stroke, less than 6 hours since last known well time. Tier 2 is 6 to 24 hours. Please remember when you're calling in your code strokes, you must give them that information. You must tell them tier 1 or tier 2. That's a big complaint that we're getting from the hospital right now is you guys are just calling in code strokes and not giving that information. So please make sure you're telling them tier 1 or tier 2. If it's greater than 24 hours, then
It's not
not a code stroke. Absolutely. Notify the hospital as soon as possible. The information on the back that says important information to note is no longer contraindications, right? It's just important information that if you can get it, if you have it, relay it to the ED staff, but it doesn't mean that you're not going to call it a code because it meets any of that criteria, except for hypoglycemia. We want to make sure that we correct hypoglycemia first.
You mean in the suspected stroke?
Yes. Syncope, orthostatic vital signs. So they must be in a seated or standing position for at least 2 minutes before you check their vitals. So if they're laying and you sit them up, or they're sitting and you stand them up, they must be in that position for 2 minutes before you check their vitals. You can't stand them up for 10 seconds and be like, okay, let me check your blood pressure really quick. You have to be there for 2 minutes. Now, Positive findings, dizziness. So if you stand them up and they get super dizzy, stop. That's as far as you need to go. Okay? Let them sit down before they fall over because they're too dizzy. Right? It may also be a decrease in systolic blood pressure by 20 or an increase in heart rate by 20 in that change in position. Consider cardiac etiology in patients who are greater than 35, diabetics and or women, and especially those with upper abdominal complaints. So this has changed. It used to be 50 in all of the cardiac stuff to suspect cardiac etiology. Greater than 50, it's now changed to greater than 35 in all of your protocols to meet the AHA standards so that we match with that. And as you guys know, since COVID, our STEMI patients have been getting much, much younger. We've had many STEMIs in their 30s and 40s because of either they currently have COVID, they previously had COVID with the coagulopathy and everything that goes on with that. So, and then tachycardia is going to be one of the first clinical signs of dehydration. UP 17 through 19 are now the behavioral protocols, and so our behavioral protocols are completely different. We're going to be assessing them and treating them based on the BARS criteria, which is the behavioral activity rating score. And so 1 is difficult or unable to wake. 2 is asleep, responds normally to verbal or physical stimuli. 3, drowsy or appears sedated. 4, quiet and awake, but normal activity. 5 is overactivity, physical or verbal. They're agitated, but they're not disruptive. 6, they're extremely or continuously active. So they're agitated, disruptive, but they're not violent. And then 7, they're going to be violent, require restraint. So first is UP 17, the behavioral health crisis. And what this does is it kind of walks us through some verbal de-escalation and how to talk to people. Okay, because we need to talk to people with respect and like they're a human being and not be jerks to them when we walk in, right? So the first thing we want to do is establish rapport. Genuine respect for feelings and circumstances. Use active listening and make eye contact to meet them at their level, right? Don't be towering over them or anything like that. So we want to make sure that we do a really good job at establishing that rapport. Remember, as we walk in and we're doing our scene size up and assessing what's going on, they're doing that same thing to us. So we don't want to walk in, we don't want to look like we don't want to be there, we don't want to look uninterested or anything else whenever we walk in to meet them. Create a quiet and safe environment, right? So if there's a lot of fire department, law enforcement, things like that standing around, ask them to step out, family, something like that. Please step in the hallway or step back so that it's very quiet and it's not overstimulating for them. Identify major problems or crisis. So what happened to upset you? How are you feeling right now? What happened to you? Things like that. And then assess for suicidal or homicidal thoughts. So ask open-ended questions, so no yes or no questions, right? We want open-ended questions to give them that opportunity to really tell us what's going on. So tell me how we can help you. What caused you to call 911 today? Things like that. Active listening. Okay, God gave us 2 ears and 1 mouth for a reason. We should be listening twice as much as we're talking. Okay, and that's really what we need to do with these patients. We need to give them that opportunity to talk. So we want to stay engaged, be able to summarize what they're saying, and use body language to convey that we're listening. So eye contact, nod your head, periodically repeating back part of what they've said to you, but don't interrupt them, okay? Encouraging, so staying positive, convey that you're interested in their care, so tell me more about that, things like that. Clarifying questions, so asking them to rephrase or repeat if you don't understand, or just clarifying, saying, so what I understand you saying is, to make sure that you're understanding completely what they're telling you. Emotional labeling, so helping them put their emotions into words, right? Because when people are really upset, it's very hard for them to identify what they're feeling and what those emotions are. So helping them with that, and then validating their emotions, letting them know it's okay to be angry, right? It's okay to be upset. It's okay to be sad. So you look upset, you seem angry, things like that. And then having a conversational pause just to give it a little bit of time for them to process the information. UP 18 is Behavioral Agitation Sedation Guide. So for bars 1 through 4, there's not going to be any sedation required, and you're just going to go do the appropriate protocol if needed, right? So at this point in time, we can determine that the patient needs to go to hospital for something else, whatever they just want to go. They don't need to go anywhere, and we can get a refusal on them. They might be a good candidate for Roxy, so we can call law enforcement to take them to Roxy, or we might be able to call mobile crisis to come out to them. So there's a lot of options for them at this point. Bars 5, they're agitated but not disruptive, so we're able to calm them, we're able to redirect them using our verbal de-escalation. Bars 6, they're agitated and disruptive, but at this point they're not violent. Okay, so verbal de-escalation, and then we can use Haldol for ages greater than 12 at 2 to 5 milligrams IM, and if they're over the age of 65, then it'll be 2.5 milligrams IM. You can repeat in 10 minutes as necessary with a max total of 10. Remember with Haldol, it takes a little bit more time to kick in than your Versed does, so give it a little bit of time. It's not going to be really instant in a minute. You're not going to see that change for most patients. Versed, 2.5 IVIOIN or 5 IM. If they're over the age of 65, then just 1 to 2.5 milligrams. For peds, it's going to be 0.1 mg per kg. With Versed, you can repeat in 2 to 3 minutes as needed with a total of 10 milligrams. And then consider the restraint physical procedure with that.
2.5 IM above 65. Remember, you said that earlier.
Oh, yeah. Over the age of 65, 2.5 IM would be your max. And make sure that you remember Haldol and Versed could be used for different things. So when do we want to use Haldol versus when do we want to use Versed?
Organic brain disease.
What'd you say?
Like organic brain disease, so like.
Is for what? What are you going to use for that?
Like dementia, schizophrenia,
What drug are you going to use for that?
how long?
And when are we going to use Versed?
Agitation.
Versed is going to be when we suspect alcohol or drug use. So you suspect substance use. Okay. Your Haldol is going to be for your true psychosis, your true brain disorders, things like that, where you don't suspect that there's any drug use or substance use. And then again, always please remember physical restraints, right? If you had used chemical restraints on someone, there's a really good chance you're going to need those physical restraints. They might be calmed down right now, but that calm down may not last forever, okay? So always consider that. And then UP19, we've changed excited delirium to hyperactive delirium with severe agitation. Because excited delirium is not a true medical diagnosis. It is just a subset of symptoms that they can kind of say, hey, this is what this is, but it's not a true medical diagnosis. So hyperactive delirium with severe agitation, we get bars 7, so they're agitated and violent. So these patients will get either ketamine 400 IM or Versed 10 milligrams IM. That's the only time that you're going to give that dose of Versed is in these patients, okay? They need fluids, right, because they're really hot. Their temp can be 103 to 110, so their brain is like a fried egg on the hot pavement in the middle of summer. Okay, so we need to cool them. So give them the fluids, 1 liter bolus, and then 150 to 200 milliliters an hour after that. Or if they still need more fluids, you can repeat with a 500 milliliter bolus up to 2 liters total. Peds will get 20 to 60 milliliters per kg with a max of 60. Again, think about your physical restraints and cool the patient with active cooling measures. Non-medical personnel requests or opinions should not be used as a factor when implementing this protocol. Law enforcement does not make our rules. They do not tell us what to do. Neither does the fire department. Okay? They cannot tell you that you need to give ketamine and you just walk on scene and do so. You need to make sure that you do your own assessment and determine if that really needs to happen. Because oftentimes they tell you that on the radio, they tell you that in your CAD notes, whatever, and you get there and you guys are able to verbally de-escalate the situation and no meds are even needed. Okay? So, okay, thank you. We've heard what you have to say, right? Take what they've had to say, but do your own assessment and try to communicate with the patient, try to de-escalate yourself. Because we don't want to end up like Colorado and have our paramedics charged with murder for over-treating someone with ketamine that didn't need it, okay? So, hyperactive delirium with severe agitation is a true medical emergency. Yes?
Peds dose of Versed or anything in that? Or is it? So it's just fluids for the peds?
You would treat with normal Versed, but not ketamine.
Well, okay, that's what I'm saying,
Yeah.
because it did have a dose station.
Yeah, you would treat with your
Versed
normal-
dosage.
Yes.
before. Okay, that's what I was checking.
They maybe have delirium, psychomotor agitation, anxiety, hallucinations, speech disturbances, disorientation, violent bizarre behavior, insensitivity to pain, hyperthermia, and increased strength. Potentially life-threatening associated with the use of physical control measures, including physical restraints and tasers. Most law enforcement agencies have policies against using tasers in these patients. Also, most law enforcement has been trained on these types of patients, and so they kind of know what to recognize, how to recognize. And a lot of times they won't engage, they'll just kind of be there and kind of surround them to prevent them from hurting themselves or hurting anyone else unless they need to intervene. If they need to intervene, they will. Otherwise, they a lot of times will wait for us to get there to do what we need to do so that they don't escalate the situation. Most commonly seen in male subjects with a history of serious mental illness and or acute or chronic drug use, particularly stimulant drugs such as your cocaine, your crack cocaine, meth, your amphetamines, and similar agents like that, flocka, bath salts, any of those things. LSD is making a big comeback, PCP, those types of things.
Why?
Alcohol or substance withdrawal can also be contribute to the condition, and then also something as simple as just a serious infection like meningitis can be the true cause. So just because someone's acting this way doesn't always mean that they are on something. It could be something truly medical that's happening causing this condition. Ketamine dissociation syndrome, treatment's going to include benzos, which may require repeat dosing. So no matter when you're giving ketamine, if they start freaking out, right, and I don't mean like, oh, there's, some green butterflies over there and they're hanging out and, they're chill and all as well. They're freaking out, they become very anxious, anything like that. If you're giving ketamine for pain and it's running, stop that infusion, okay, and give Versed. Otherwise, if you've given it for this, then go ahead and give some Versed for that to help relax that anxiety. Treatment also includes decreasing ambient stimulus, such as lights, sounds, activity, things like that. So if you need to dim the lights in the back of the truck, be very quiet, things like that. Ketamine can also cause hypotension as well, hypertension, vomiting, respiratory depression, and laryngospasms. So if they have laryngospasms, we want to make sure that we use the BVM and start bagging the patient until it corrects itself. Okay. Adult airway, all of your adult airway protocols, the supplemental oxygen goal was increased to 92%. It was 90, so it's been increased to 92 in all of them. Making sure that we use continuous SpO2 and waveform capnography on all of these patients with respiratory distress, respiratory failure, all intubated patients, this includes a kinking airway, and all patients who receive ketamine, Versed, and or fentanyl. Okay. Ventilation rates is going to be 10 to 12 now to maintain entitled 35 to 45, where it used to be 8 to 10. So the state increased it to 10 to 12. AR1 adult airway. Versed 2.5 to 5 can be given to the patient in order to tolerate airway management techniques or procedures. Okay. So if you have someone who needs CPAP and they can't tolerate it, you're trying to get them on the CPAP, you can give them a little bit of Versed to help them tolerate that so that the treatment can actually be effective. As far as your difficult airway assessments, they changed all of them. So difficult BVM is now Roman. So radiation, treatment, restriction, obese, obstruction, OB, second, third trimesters, obstructive sleep apnea, mask seal difficulty, so hair, secretions, or trauma, and then age 55 and no teeth. Difficult laryngoscopy is now Leon. So look externally for anatomical distortions, small mandible, short neck, large tongue. Evaluate 3-3-2 rule. Mouth open should accommodate 3 patient fingers. Mandible to neck junction should accommodate 3 patient fingers. And chin-neck junction to thyroid prominence should accommodate 2 patient fingers. Obstruction, obese, OB, second or third trimester, and then neck mobility limited. And difficult biad is rods, radiation treatment, restricted mouth opening, obstruction, obese, OB, second, third trimester, obstructive sleep apnea, distorted or disrupted airway, short thyromental distance, small mandible, stiff lung, or cervical spine. And then difficult crike is SMART, surgery or distortion of airway, mass or hematoma, access or anatomical problems, radiation treatment to face, neck, or chest, and then tumor overlying the neck. So if you are looking to have to do any of these things to your patient, those are things that you need to be looking for, observing, and assessing for to know, so you can anticipate if this is going to be a difficult airway for you or not. Drug-assisted airway, so the indications are going to be failure to protect the airway, and or unable to oxygenate, and or unable to ventilate, and or impending airway compromise. So when you look at the protocol, if they are hypoxic, this is where it changed a little bit, hypoxic or hypotensive or dangerously combative. Yes, then you can give ketamine 1 to 2 mg per kg IV or IO. But if you don't have an IV or IO now, you can give it the IM route at 400. Okay, so that changed. And this is still leads or supervisors, ketamine only for airway. And you have to have your 2 paramedics on scene. But they did change that so it can be given IM if you don't have access. Yes.
Since we're having the incidents more of EMT trucks, can the lead just do it by themselves? Put them in the
The
medic?
state requires 2 paramedics to be on scene.
Making sure.
Yeah. That's not a us rule.
I understand. That's one of the,
Correct the hypoxia or hypotension, and then go to the appropriate airway protocols from that. If they're not hypoxic, hypotensive, or dangerously combative, then you're just going to go with 1 to 2 mg per kg IV or IO, and then you can repeat it 1 time, and then you can give back if needed. We split up asthma and COPD because they are 2 completely different airway diseases, and so we treat them completely different. So for asthma, you have wheezing, and then you have stridor. EMTs can give albuterol as long as it is prescribed to the patient, right? So Fayetteville Fire Department will be doing this as long as it is prescribed to the patient. Okay, our EMTs can also do that. Under stridor, you see it goes from albuterol to an epi nebulizer, and then you're just going to follow through the rest. At the bottom, you have mag sulfate. Okay, is at the bottom for a reason, because that should not be your first line drug that we use in airway patients. Okay, so we want to make sure that we're kind of giving the rest of the stuff a chance to work. And you guys can completely choose based on your patient and what they need. You can do a DuoNeb first. You don't have to start with albuterol. Okay, it's just albuterol is all that the basics can do. As a paramedic or as an AEMT, you can start with a DuoNeb if that's what your patient needs. For COPD, they're wheezing, right? So we're going to do nebs. You can use the NIPP procedure. And then if you notice at the bottom, it stops at Solumedrol. There is no MAG. Okay, we do not give MAG to COPD patients. We split these up because people were given MAG just to anybody that was a respiratory patient because they're respiratory, so they need MAG. And that is not at all the case. MAG and COPDers can actually make them much worse. So we want to make sure that we're only giving it for the appropriate patients and when it's time. Like we've tried other things first and nothing is helping. NIPPV can be used with COPD, asthma, allergic reactions, and or CHF. We want to consider it early on in the treatment course. And if their systolic blood pressure stays less than 100 and they're not responding to other treatments, then we want to consider taking it off of them. AR7, pediatric asthma, respiratory distress. Theirs is divided up into wheezing asthma and then stridor croup. So they have your albuterol, your epi nebulizers. And if you come down to the bottom of this one, you have MAG, but it is only if you contact medical control first. Okay, you have to contact medical control first in order to get orders to give MAG to pediatrics. Bronchiolitis, croup, and epiglottitis is explained on the back of the protocol. So bronchiolitis is a viral infection that affects infants, usually resulting in wheezing that may not respond to beta agonist. So consider your epi nebulizer in these patients if they're less than 18 months and not responding to that. Croup is typically kids under the age of 2. It is viral, They may or may not have a fever. It will be a gradual onset, and they're not going to be drooling. Epiglottitis is the opposite of that, typically greater than the age of 2, is bacterial, fever, rapid onset, possible stridor, and they want to sit up so that they can keep their airway open. There's going to be a lot of drooling, so we want them to be able to maintain whatever position of comfort they are in and try not to manipulate their airway, because then we can make them worse. AR8, post-intubation VIAD management. So once they are successfully have airway in place, we want to maintain the SpO2 greater than 92%, using the age-appropriate breaths per minute, and adjusting that for the entitled to be 35 to 45. If they're awakening or moving after that, or they become anxious, or there's evidence of agitation, then we're going to go to the treatment arm. You can give ketamine at 1 to 2 mg per kg, fentanyl 50 to 75 micrograms, repeating every 5 minutes up to 200. Pediatrics would be 1 mic per kilo, and then repeating at 0.5 with a max of 2. And then Versed 2.5 to 5 IVIO, and then peds would be 0.1 mg per kg with a max of 10. And then you can, leads and supervisors can consider a long-term paralytic such as VEC on these patients. So if they are already intubated, they already have a kink airway in place, this is where you as a paramedic on the truck, not a lead, not a supervisor, can give the ketamine to maintain that airway. Okay, if they're waking up, they're becoming very anxious, very agitated, they're bucking the tube or anything like that, then you can go ahead and give the ketamine for that.
It still need 2 minutes.
Don't need
Not for that. Only if you're using it to assist in implementing that airway. Unrelieved pain can lead to increased catecholamine release, ischemia, and immunosuppression, and prolonged hospitalization. So we want to try to prevent that from happening. So our sedation strategies, pain is the primary reason these patients experience agitation, and so we want to address that first. Opioids and or ketamine are going to be your first-line agents, either by themselves or in combination. Benzos may be utilized if the patients are not responding to adequate opioid or ketamine doses. Paralysis is considered as a last resort, and only when they're not responding to them at all. And patients who have received paralytics may be experiencing pain with no obvious signs of that, so we want to make sure that we consider sedation with those patients. Yes?
So in the pain control protocol, it says the repeat of 25, but here it just says repeat of 50 to 75. So if we're doing it for the post-intubation sedation, it's repeats of the 50 or 75, depending on the weight, correct?
Mhm.
Okay.
Yes. Head of the bed should be maintained at least 10 to 20 degrees of elevation when possible to decrease aspiration risk. Okay. So we actually there was a patient the other night that was started waking up and bucking the tube, and they tried Versed and fentanyl first, and it didn't work, and then they ended up giving ketamine, and so the 3 of them combined was actually what worked for that patient. So sometimes it may only take 1, sometimes it may 2, sometimes it may take all 3 in order to get the results that you need for the patient. AR9 is ventilator emergencies. You can see that it's going to walk you through the different things that can happen, but most importantly, if the ventilator is not working, what are we going to do? Disconnect it and bag. Okay, don't sit there screwing around with the vent trying to figure it out for a long time and the patient's not adequately being ventilated. So disconnect it, bag them, and let somebody else work and figure out what's going on with that. Making sure that we talk to family or the caregivers, right, because they know the machine, they know the patient, they're going to be able to give you the most information. If they are on a vent, we want to make sure that caregiver goes with us, so because they're the ones that know how to operate said vent, right? Use their equipment if it's functioning properly. If unable to correct it, we're going to disconnect it and use our BVM. Take their ventilator to the hospital, even if it's not functioning properly, right? Because if it's not, then the hospital needs to know about it, and they need to make sure they have properly functioning equipment before they go back home. And the typical alarms that you may see is going to be low pressure apnea, so there may be a loose or disconnected circuit. There could be a leak in the circuit or around the tracheostomy site. There may be low power, so the internal battery is being depleted, or a high pressure alarm, which is going to be from a plug or obstructed airway or a circuit. Tracheostomy tube emergencies. This looks like a really busy protocol. There's really no other way to make it less busy. I stared at it for a really long time, and you just can't, because of all the different things that can happen. A couple of different pictures of them there. So the biggest thing, again, talking to family and caregivers, because they're going to know the patient, the equipment, and everything. Ask them if they've undergone other injectomy, because if so, you're not going to be able to bag them or anything, because there's no mouth nasal ventilation. Use the patient's equipment if available and functioning properly. Estimate suction catheter size by doubling the intratracheostomy tube diameter and rounding down. For suction depth, ask family or caregiver, right, what do they normally suction at, because they're going to know, but it should be no more than 3 to 6 centimeters. And typically you need to make sure that you squirt 2 to 3 mLs of normal saline first before you suction, in case there's that thing mucus plug and you need to help break that up. Don't call me for that. Do not force the suction catheter. Don't call Pam either. If you can't get it to pass, then the trach tube should probably be changed. And then always make sure that you deflate the tracheal tube before you remove it. Please, just like you would a King Airway or anything else, please deflate the tube first. And then make sure you're using constant SpO2 and end-tidal. For the adult cardiac protocols, we divided asystole and PEA into separate protocols. Asystole will be staying on scene for a minimum of 25 minutes and working the arrest. If there's no change after 25 minutes, then we're going to call a code. And that is 25 minutes from you all being on scene, not 10 minutes for our department, 15 minutes with us. It's 25 minutes of you all at patient side working the patient. PEA, we're going to load and go to the hospital. We're going to take our time. We're not going to rush, right? But we're going to get them to the hospital, because there's a whole lot of things that they can do at the hospital that we cannot do to correct those H's and T's. VFib, VTAC, we're going to work them on scene for about 10 minutes while we make sure we have an IV or IO, we have an airway established and end-tidal, and everything is in place before we move the patient. And sodium bicarb is no longer recommended for a renal patient, is only recommended, for renal patients, hyperkalemia and tricyclic antidepressant overdoses. This has been the case for years now. It's in our protocols like it is, but some people are still stuck in our old protocols and think that we just give sodium bicarb automatically for any unknown downtime. That is no longer the case, so please stop doing that. It is only for renal patients, hyperkalemia, and TCA overdoses. If they meet this criteria, then we don't have to work them. Decomp, rigor mortis, dependent lividity, blunt force trauma, injury incompatible with life, extended downtime with asystole. Extended downtime with asystole is not 20 minutes. Okay? We haven't seen them in a couple hours, they're cold to the touch, things like that. Okay? Otherwise, you must work it.
Just to reiterate, we are not calling anything in PEA in the field. You're transporting a PEA. You can call the PIC and get orders. It's not recommended to do that, but Dr. Wells does not want anybody calling a PEA arrest in the field.
Unless it meets one of these.
It's
So,
not going to meet
it's
any of
not.
those.
I was gonna say,
Well, I
not
mean,
gonna
I'm
meet that.
talking like injuries incompatible with life from like a motor vehicle, right,
No.
but they're in PEA.
No, that is traumatic arrest. That's completely different. Yeah.
Cardiac arrest. Cardiac arrest.
This is currently in your protocols, but most people don't know that this exists. So if you are the first arriving unit on scene, or it's just you and your partner on scene, and your patient goes into cardiac arrest, one person is going to do CPR and the other patient is going to do what? Who said that? Good job, Ryan. Put on a non-rebreather. Okay? Slap that non-rebreather on. Doing CPR, the negative pressure is going to cause passive oxygenation, and that patient is going to be fine for 6 to 8 minutes like that. Okay, so there's no rush to get an airway in that patient. One person doing compressions while the other person can do all the other things that need to happen. We need to get the patient on the monitor. We need to get the pads on the patient. We need to get an IV or an IO, right? Get fluids hung. Give that first dose of epi. Whatever it is, Once we've done those things, right, then we can worry about the airway, because if we go ahead and put in an airway, now what?
Nothing.
You're stuck. Exactly. No one can do anything else. Okay? So the first thing we want to do is compressions and a non-rebreather. If you are 2 minutes from the hospital and your patient goes into cardiac arrest, what are you going to do? Keep driving. Do not stop. Do not tell your partner to stop. Keep driving. Do compressions and just go. You are almost there. Just update the hospital and let them know. Hey, we're getting ready to pull in. Our patient just coded. This is what we got.
Yep.
Okay? That's all you need. It works great. Right? We teach hands-only CPR right now to the general public anyway, as it is, if they don't have a way to breathe for the patient. So it's going to be fine. We do constant compressions. We don't do 30 and 2. We do constant compressions with our ventilations. Special considerations. So maternal arrest, treat the mom for the appropriate protocols, okay, and let the hospital know immediately that this is a maternal arrest. Making sure that we put them seat time and do a manual left uterine displacement, so physically moving the uterus to the left side. IVIO access preferably above the diaphragm, and then defibrillation is going to be safe at all energy levels. For your renal patients, we already talked about that. You can give bicarb and calcium, but we want to get those two on board very quickly. Opioid overdoses, if that's what you suspect, then we want to make sure that we ensure we have proper airway and oxygenation, and then and chest compressions, and then you can treat with Narcan. Drowning, suffocation, asphyxiation, pain, need lightning strikes. Most often hypoxia is going to be associated with those, and so we want to make sure that we address that right away with our continuous chest compressions and then early defibrillation. And then hypothermia. Requires prompt transport, active warming measures, and prolonged CPR. We don't want to give any medications until their temp is greater than 86 degrees Fahrenheit, and only one defibrillation if it's less than that. Being very careful with these patients, moving them very easy so that we do not jar their bodies, cause their heart to go into fibrillation if it isn't already, or anything like that. So we want to be very, very careful whenever we're moving these patients. AC8 is polymorphic tachycardia, so torsades has its own protocol. Unstable or serious signs and symptoms. So you want to consider, sedation. However, most patients in torsades are going to be unconscious. Okay, Versed 2 to 2.5, and then we are going to defibrillate them. We're not going to cardiovert them starting at 200. 203, 360. For our regular cardiac arrest defibrillations, we just go straight to 360. This one we're going to start at 200. If they have a pulse present, then you can consider MAG at 2 grams. However, I don't think they'll have a pulse for long. AC9, VFib, or pulseless VTAC. If it is refractory after 3 shocks, then we want to consider changing the vector of our defib pads. So what does that mean?
Change the pads themselves.
Changing.
The pads themselves.
Just
Positioning.
put new ones in, or
Positioning.
so changing their placement, right? And changing the pads, right? So you can move them, you can adjust them a little bit, or you can make a sandwich with the pads, okay? So making sure we're moving them, changing them. He just called me too, so I don't know what he needs to check. IVIO access and drug delivery is secondary to high quality chest compressions and early defibrillation, okay? So the first thing we want to do is compressions, early defibrillation, and then we can worry about IV access and given access and given drugs. We no longer are going to be doing dual sequential defibrillation. That protocol is gone because it was proven that it didn't work. Okay. Post-arrest, post-resuscitation. So we've got them back now. So what do we want to do? In that first 10 minutes, we want to make sure that we have access, that the airway is secured, we have good entitlement in place, we have a 12 lead, and if needed, that we transmit that 12 lead. All vital signs have been taken. Establish a second line, make sure we have good history and medications and on that patient. Again, their heart is like, what the heck just happened, okay? So we want to be very easy with them, taking our time, not rushing, not jarring them, not shaking them around, so that we don't put them back into cardiac arrest. So we're going to take our time and make sure we have all these things established first. Arrhythmias are gonna be very common and usually self-limiting after ROSC, so give the heart time, right, to kind of stabilize. If it persists, then go to that appropriate protocol, but we don't want to treat an arrhythmia right away and cause them to go back into cardiac arrest.
That's the same for pacing.
Pardon me?
That's the same for pacing, wait for.
Yeah. Chest pain, so the STEMI criteria changed, this is per the AHA criteria. So, STEMI definition is, sorry, I did all the cardiac arrest ones together. Sorry, I want to do all the cardiac arrest ones together. So greater, equal to, or greater than 1 millimeter ST segment elevation and 2 or more contiguous leads. Greater than or equal to 2 millimeters of ST J point elevation and V2, V3 for men. And then in women, it will be 1.5 millimeters.
One or all
One. Yeah, it has to be one of that criteria. I'm right on that. Code STEMI meets STEMI criteria. Okay, patient meets STEMI criteria. We're going to call it a code STEMI. Code medical cardiac event. They have findings suggestive of an MI, but the 12 lead is normal. You walk in, they're pale, cool, clammy, they're gray, they have chest pain, they look like crap. You print that 12 lead, and you're like, how is this not a STEMI? Okay, looks like a STEMI, but the 12 lead is normal. Or there is a 12 lead that has a STEMI, but there's imposters. Okay, and they look like they're having a STEMI. Okay, this isn't just going to be someone that has a left bundle branch block and they're there because they stubbed their toe. Right, we're not going to call that a co-medical cardiac event. If I haven't already, I'm going to be turning on a tab in the flow chart that is cardiac alert. And that will be for these patients, right? We have STEMI, stroke, trauma, but we have nothing to track our co-medical cardiac events. And so I'll be turning that on so that anytime you have a co-medical cardiac event, you're going to document that time that you alert the hospital in there so that we can better track how many of these we're having. Consider placing 2 IV sites, preferably in the left arm. They frequently use the right radial for intervention, and so we don't want to use that site. Place defib pads on the patient as a precaution because you never know when they will go into a sudden VFib arrest. Consider crystalloid solution bolus of 250 to 500 milliliters as a pre-tap hydration. Our goal time for the scene is going to be less than 10 minutes. What is our goal time for the EKG? 5. Welcome back, Chuck. Good job.
Don't go that
Oh my.
That was Chuck Arena talking.
Chuck Arena. Yes, so you want to have your EKG within 5 minutes of first medical contact. We want to limit our scene time to 10 minutes, and we want to notify the hospital within 10 minutes of first medical contact. Okay, so make that notification and make sure it's documented and timestamped in the chart. Adult tachycardia narrow. If they are unstable, then consider sedation prior to cardioversion. They will be very appreciative of that. And you can give Versed, IVIOIM, or IN. So you don't need a line to do that. If you're going to kick them in the chest with a mule, then please make sure that you give them a little bit of sedation if you can and if you have the time. Okay. Narrow and regular, you're going to start 50 to 100 joules. Narrow and irregular, you'll start at 120 to 200. So if you start at 100 joules for everyone, it's a safe bet on a narrow complex. You can repeat and increase the dose with each attempt. If they're stable and it's a regular rhythm, you can attempt vagal maneuvers and then adenosine 6, 12, and 12. Now, remember, we need to make sure that they're actually SVT and not just sinus tach. Right? Grading has a temp of 103. She's burning up. She has a heart rate of 160. Probably not SVT. She probably doesn't need adenosine. What does she need? Some fluids. Exactly. Okay. If it is irregular, then they need metoprolol, 5 milligrams. Okay. Rate control is going to be a lot more important at that point as opposed to rhythm conversion. We just want to bring that rate down. It does not say consider adenosine. Okay. We do not consider adenosine for AFib. It doesn't work. We don't need to waste the time giving it, so don't do that anymore, okay? It's really easy to determine on the monitor if it is AFib. You just look at the number, and if the number is all over the place, that's a good indication that it's AFib. If it's hanging out at 160, 162, 160, 162, it's a good indication that it's not AFib, okay? That's regular versus irregular, so. Adult tachycardia wide. So on the back of this protocol, it spells out the difference in SVT with aberrancy and VTAC. They are both wide complex rhythms, and a stable patient doing a 12 lead can help differentiate between the two. If you do a 12 lead and the patient is in VTAC, your 12 lead will not tell you that they're in VTAC. That is something that will never print out on your 12 lead, okay? VTAC has a positive R wave deflection in V1 and negative in V6 and is indicative of an extreme right axis deviation, which is going to be usually a result of VTAC. There may also be negative R wave in 1, 2, and 3, and so that's also indicative of right axis. For SVT with aberrancy, you'll have a negative R wave in lead V1 and positive in V6, and that is going to be indicative of a normal axis. So you want to make sure that you're really looking at that will probably be SVT with aberrancy. And oftentimes you'll be able to see P waves in those also. AC 14, 15, and 16 are new protocols. AC 14 is mechanical circulatory support, LVAD, RVAD, and BIVAD. It's like 4 pages long, but it lays out what each one specifically is, what to look for, what to do. What's the most important thing we want to do, take with us to the hospital?
Batteries. Told y'all. Hero.
Make
Just
sure you
told that
have
story.
those batteries. Yes, yes.
People that are on LVADs, is there supposed to be like a registry for them in Cumberland County? Or is that not a thing?
It's not a thing for us. The hospital gets told, and we are left out of the loop.
Sometimes if they go to Duke will send a letter to EMS or to dispatch, but
I've gotten one of those letters in like 4 years.
Like once I
I
feel
just
like
have
we were notified.
family say that
Here, now?
we were supposed to know because they're on.
The
list.
hospital, they send the information to the hospital,
Yeah,
so the
I mean,
hospital knows that they have a patient in the community.
it just doesn't get sent past that.
Yeah,
And I think that's really just because we're owned by Cape Fear Valley. And I'll just say that because at Harnett County, I got a letter all the time.
And I've reached out to them, like I've reached out to people and asked about that. Oh yeah, we'll make sure you get it. And
We have no idea where they send it to.
it's just kind of a big deal when we show up to somebody.
just a little.
Sometimes the fire department gets a lot, I know I got a lot of them when I was a youth worker, but I mean, it depends if they,
They may not do anything with them. Yeah.
Yeah.
Share that.
so
No one shares it with
the whole
EMS.
communication thing.
Well, yeah, like, they didn't burn it yet.
Mm-hmm.
Or unless
You're
we
not
get there, we
going
tell somebody, hey,
We had a list.
can we flag this?
AC 15 is total artificial heart. And then 16 is wearable cardioverter defibrillator vest. They have one of those. Make sure you take any parts, batteries, pieces, anything like that that it may have that needs to go with it also. Allergic reaction, anaphylaxis. So oral Benadryl has been added. Again, this is something that the fire department will be adding also. So they may have already administered Benadryl when you get there, so make sure that you ask. So EMT can administer albuterol, again, if it's already prescribed to the patient. If the patient has severe anaphylaxis and is not responding to Epi-IM or in fluid resuscitation, then Epi-IV should be administered. And you're going to make Epi 1 to 100,000 by taking one Epi 1 to 10 and putting the whole entire thing into a 100 bag of D5W and running it in IV. And you're just making a dirty Epi drip.
If fire gets Benadryl and they give Benadryl before we get there, is that patient still allowed to refuse, or do they have to go because fire gave them Benadryl?
So fire department should not be getting refusals on any of those patients. We should still be going and assessing them and then determining what needs to happen with that patient.
Okay, but they don't, it's not like a thing like, well,
You can't make them go.
right, you took this, now you have to go. It's not like,
You can't make them
You
go
can't
if they
make them
meet
go.
with the refusal policy.
You're gonna encourage them, but if they're really sick, you know, and it's not just a simple mild allergic reaction, then we want them to go, and then it would be high risk, and we would want to call
Right.
lead and then a PIC if needed.
talking like ant bites or something, that somebody got ant bites and
Or
got
ant bites
Benadryl.
could be
Right, I
anaphylaxis.
absolutely believe that, but what I'm asking is that they are still allowed to, when they meet the criteria of the refusal, refuse, even though they've gotten a medication already.
Yeah, we can't kidnap anyone and make them go to the hospital.
Okay.
If it's high risk based on their presentation, then you would need to call a PIC if the lead is not comfortable with that refusal. Yeah. Diabetic, so we're adding oral glucose to the trucks. Fayetteville Fire Department will also have that. For adults, you'll give 1 to 2 tubes. It's only 15 grams, which is what is in a bite-sized Snickers. I mean, that's legit. That's what is in a little teeny tiny bite of Snickers is 15 grams. So 1 to 2 tubes for the patient. Obviously, if they can eat or drink, we want them to do so. If they have prolonged hypoglycemia or if they're malnourished, they're not going to respond to glucagon, so this will be a much better option for them. Don't administer oral glucose to those who are not able to swallow or protect their own airway, though, please. Please don't just still squirt it in their mouth, okay?
Stick it up the butt.
So you can. We're not allowing that, but that is an option.
I
It
mean, I'm
actually
just
is.
saying.
It's actually a route
You
that
can
you can
eat it,
give
you can shoot it up. you
Yeah.
can shoot it.
rectal glucose. We're not doing that. So peds will be a half to 1 tube. So. Dialysis renal failure, we added these charts in there for you guys to see and understand the signs and symptoms of hyperkalemia, and then what the rhythm and the QRS is going to look like and how they may present. And then we also added this chart in there for DIG toxicity. Please don't give these patients calcium if you suspect DIG toxicity. That is what how they will present to you. AO2, newly born. We added all of these in there. So most people, unless you've taken neonatal resuscitation program, you won't understand that pulse ox in newborns is low.
Yeah.
And that's normal. And it takes up to 10 minutes for it to get to normal. Okay, so we put all of them in here so that you will understand, way before that, what the readings will actually be. Most newborns require resuscitation will respond to ventilation via BBM, compressions, and or epi. If they're not responding, then consider hypovolemia, pneumothorax, and or hypoglycemia. Hypoglycemia in these patients is going to be less than 40 in your newborn. Okay, so you're going to give D10 5 mLs per kilogram. Or it may not.
I might just not have it.
No, it's not. Yeah, these aren't it.
Okay.
I'm looking crazy. I'm glad you were tracking her, making me feel crazy.
Listen, I printed so many of them yesterday, I'm not sure which ones are and aren't. Okay. I'm delirious at this point, going on 3 hours of sleep. But it's very hard to determine that small amount of D10 when you're administering it, so just draw that out in a syringe and then push that IV in them. Airway suctioning of the newborn is no longer recommended, just routine suctioning. If they have clear amniotic fluid, suction only when there's an obstruction present or if BVM is needed. And then if meconium is present and they're a non-vigorous newborn, then positive pressure ventilation is recommended. We no longer do ET2 with meconium, aspirate or anything like that. We're just going to bag them. OB emergency, if they are having a seizure, then you're going to treat with Versed, 2.5 to 5, and then you can repeat with a total of 10. If you suspect eclampsia, then you're going to give MAG 2 grams over 2 to 3 minutes. But please, please, please treat the seizure first. Okay, give the Versed for the seizure first, and then treat the eclampsia. Okay. Patients can be preeclamptic or eclamptic up to 8 weeks postpartum. It is not just while you're pregnant. It is up to 8 weeks postpartum. If they're greater than 20 weeks gestation and they've been involved in an MBC, then it's typically going to require 4 to 6 hours of fetal monitoring. Please do not tell them or suggest that they need an ultrasound, because most of the time they don't. They get to the hospital and they're like, oh, they said I needed an ultrasound, and then they get really mad because the doctor doesn't feel like they need an ultrasound. Okay, so don't suggest that, don't recommend that, just tell them that they need to have, they need to be evaluated and monitored for a little bit. TB3 crush syndrome. So if they are entrapped for less than 2 hours, crystalloid solution infusion, 1 liter per hour. Peds will be 3 times the maintenance fluid rate. If they've been entrapped greater than 2 hours, then you're going to give a 2-liter bolus and then 500 milliliters per hour. For pediatrics, you'll give 20 mLs per kilogram and then the maintenance fluid rate. If they have an abnormal EKG, so peak T waves, the QRS is wide, the QT is greater than 0.46, they have loss of P wave, or hemodynamically unstable, or they're in cardiac arrest, then you're going to treat them with bicarb, calcium, and albuterol. We want to make sure that IV fluids prior to release of the crushed body part, especially if they've been crushed greater than 1 hour. Making sure that if it is greater than 2 hours, that we're given that 2 liters of fluids, and then or 20 mLs per kilogram for peds, and then starting the greater than 2 hour dosing regimen. If you're not able to get an IV or IO immediately and start that fluid resuscitation, then put a tourniquet on that limb until you can get fluid started. Okay, you're not putting it on there for hemorrhage control. Go ahead and put that tourniquet on until you can start fluids. Traumatic arrest, TB10. You can pronounce them if they are asystole or wide complex PEA less than 40. This is the only time that you can pronounce PEA. Has to be wide complex, less than 40, with trauma, blunt or penetrating trauma. Lightning strikes, drowning, or in situations that causes hypothermia, then we want to make sure that we initiate resuscitation regardless. And we're going to limit the scene time to less than 10 minutes. Now, that doesn't mean that we're going to rush, throw the patients around, freak out, and have a circus on scene, right? We're still going to take our time, do what we need to do to safely move the patient, safely get them to the truck, and get them to the hospital. We just want to try to limit our scene time as much as possible. Yes?
Hate to regress to the crushing area one. If they're crushed at their pelvis, do we want to do bilateral tourniquets on their lower limbs? And just from, I mean, you said put a tourniquet on there until we get there. Is that gonna be there forever? I mean, what, I mean, can't we turn,
Just put a belt around their belly.
I'm just from prior experience and whatever happened in the recent past, I don't know what.
I think we'd have to ask Dr.
Yeah, I was
Wells.
going to say, that's a great question. We'll ask Dr. Wells about that.
Cause I mean, sometimes you get pinned and you're not just pinned by one limb, but you're pinned by your lower part of your body.
Yeah.
We'll ask.
Sorry, didn't mean to regress.
No, you're fine. Pediatric pulmonary edema, or CHF. We want to make sure we put the head of the bed at 25 to 40 degrees, flexing their hips with support under the knees so they're bent at 90 degrees. And then any other treatment of them is going to require medical control. Okay, so they're going to have to contact medical control for that. And you can ask for fentanyl, 1 mic per kilo, with a max dose of 50. Nitroglycerin, they'll determine what that dose needs to be. Obviously, if it's not 0.4 sublingual, it will have to be nitro paste, and they'll tell you what to do with that. And then dopamine will be 10 to 20 mics per kilo per minute, titrated for systolic blood pressure for the age of the patient. Every other protocol that has dopamine in it, it's 2 to 20. And we just made that uniform through all the protocols. This one, because it's peds, is 10 to 20. Most children with CHF have a congenital heart defect, so we want to make sure that we get really good history on these kids. And it's gonna vary by age. So if they're less than 1 month old, then they're probably going to be a TET baby, or they may have transposition of the great arteries or coarctation of the aorta. 2 to 6 months, they may have VSD or ASD, and then at any age, they may have myocarditis, pericarditis, SVT, or heart blocks. Do not assume all wheezing is pulmonary, especially in a cardiac kid. Okay, remember, not all wheezing is asthma. We have to be very careful and make sure that we avoid albuterol in these kids unless they have recurrent issues of wheezing secondary to pulmonary etiology. Pediatric tachycardia wide complex. Okay, if it's regular, they're stable, it's probably going to be VTAC. Regular monomorphic, you can attempt adenosine 0.1 mg per kg with a maximum of 6 and may repeat one time at 0.2 mg per kg, maximum of 12. And then after that, you're going to consult the PIC for any further medication management or cardioversion procedure. TE1, bites and envenomations. Spider bites, beaver wasp sting, snake bites, and mammal bites. So before, a lot of people wondered about the Versed under the spider bite. I know I did, and I asked a long time ago, why the heck is Versed under the spider bite, right? So it's explained now, if they're having severe muscle spasms, abdominal cramping, things like that, it occurs in a very, very small amount of black widow bites. Then you're going to give 2 to 2.5 of Versed for that. For snake bites, keep the bite at the level of the heart if you're able to. Do not put ice on it. And then mark the margin of swelling and redness and the time. And then as it increases, keep marking it so they can see how rapidly it is progressing. Most importantly, do not take snakes or animals to the hospital. Take a picture if you have to, but please do not take them to the hospital. Okay? TE2, carbon monoxide cyanide. Both of these charts are in there. So the one on the left is going to be the readings from the LifePak 15. The one on the right will be the readings that the fire department will get from their air monitors and what the symptoms would look like based on those readings. If you are on scene and you have a sick patient that needs to go to the hospital, please do not wait on a leader or supervisor to get there with their monitor so that you can see what their CO reading is. Get them to the hospital. Okay, if they're not sick, they want to refuse or something like that, you want to wait till they get there because you kind of need to see where they are, that's okay. Understanding that smokers will naturally have CO reading all the time, usually in that 0 to 4 up to 9 range, depending on the person, how much they smoke. Chuck.
I'm probably about 13 to 15.
Yeah, we need to put you on there and check it out. Chuck Arena. Drowning, no matter what the water temp is, resuscitate all patients if they have a submersion time of less than 25 minutes. If it's a greater than 1 hour time, then you're going to move to the recovery phase instead of rescue phase.
That means just finding that,
Yes.
right?
Overdose, toxic ingestion. So this is like 3 pages long now. But they did a really good job of breaking it down into very specific different overdoses and ingestions. So the first one, you have inadequate respirations, oxygenation, ventilation. If that's the case, then we're going to do Narcan, and I know it says mg per kg up there. That's not correct. It's just 0.5 milligrams. We'll fix that. But making sure that we are only treating for inadequate respirations, oxygenation, ventilation. We don't treat them because they're a little altered. We don't give Narcan because they have pinpoint pupils, right? We're only giving it when it affects their respiratory status. Yes. Can repeat as needed. Titrated to affect adequate ventilation and oxygenation. Now, if someone is breathing 10 to 12 times a minute, their SpO2 is 95 and their end-tidal is 90, is that adequate? No. That patient still needs a little bit of Narcan because that end-tidal of 90 is not adequate or effective, okay? We don't give it to restore consciousness. We don't care if they wake up. That is not our goal, okay? We do not care. In fact, we prefer for them not to wake up. They're much easier to manage that way. Okay, so just give enough. Give it a couple minutes. If you have to give another dose, remember, they may not just automatically stimulate and wake up. Just like some diabetics, you give the D10, you have to kind of stimulate them, right? Same thing with Narcan sometimes. You kind of have to stimulate them a little bit and then they start breathing effectively, okay? Narcan adverse reactions, vomiting and aspiration, increased blood pressure. If they are on clonidine, it can actually reverse that and can cause a significant increase in blood pressure. They may become tachycardic. They may have aggressive behavior, as we have all seen. And then if there's someone that is physically dependent on opioids, like especially your elderly people who have been taking it for a long time for chronic pain, and we give them that, then we're going to put them into acute withdrawal syndrome, and we do not want to do that, okay? Then you have your beta blocker or calcium channel blocker overdose. If they're a very severe case, then you can consider pacing. Glucagon, 2 to 4 milligrams IV/IM, okay, and you can repeat that in 15 minutes as needed. Calcium, dopamine. Okay, levo is in here because that is our goal. Our goal is to get levo. However, we have to have pumps first. So our first hurdle is getting pumps before we can even think about switching to levo instead of dopamine. Organophosphate or WMD, nerve agent exposures. You're going to give atropine 2 milligrams IV/IM/IO for adults. So the one thing about this is the way our atropine is concentrated, to give it IM, you would have to literally stick them a whole bunch of times all over the body, right? So please don't do that. Give it IV or IO. Tricyclic antidepressant overdoses or TCAs. If it is a QRS of greater than 0.12 or impedes greater than 0.09, then you're going to treat with bicarb. And then on the back has overdose signs and symptoms for all the different things. The procedures are listed in this order. There'll be airway, assessment, cardiac, parenteral access, respiratory, universal, wound care trauma, and agency specific. The policies will be disposition, documentation, EMS dispatch, medical, pediatric, service metric, toxic, environmental, transport, and then agency specific. All right, so with CAS, we had to set up some benchmarks, our goals of specific skills, times, and things like that. And so this is what we kind of decided on and went with. Our goal for IVs is to be 75% successful. We're not. For the third quarter, we were 64%, and that's pretty consistent. We're usually between 59 and 64%. We are running the numbers for each person individually, and if you fall very low, you will be taking a trip to the ED for a few hours to do IVs over there to get IV practice. IOs, our goal is 90%, we're at 91. Decompressions, 90%, we're at 100. ET tubes, 80%, we're at 70%, which is a huge increase over last quarter. We were at 30%. King Airways, our goal is 90, we're at 94. And CREX, we've only had one this entire year, and it was successful. Our total volume is 17,238 for the quarter. Our refusals were 1,667, so our goal is to be less than 15%, and we're at 10%, so that is really good. Our trauma scene time, we want to be on scene less than 10 minutes, 50% of the time, and less than 15 minutes, 75% of the time. So we're right at it for the third quarter, with our average scene time of 11 minutes and 52 seconds. That is really good. Like, we are really happy with that number, because when you look at your traumas, a lot of things can skew those times. If you have a couple of long extrications and stuff like that, then that will totally skew it. And we're still hanging out at 11:52. So we are really, really happy with that. And so is trauma services. STEMI scene times, our goal is 10 minutes, and we suck. We only meet that 20% of the time. Less than 15 minutes, we're at 72%. Our average scene time is 13 minutes and 47 seconds. So we have to get better than that 3 minutes, by the way.
Yep, it was like 2
Um,
minutes, 47 seconds. I saw that. And our transport time was like right at 20 minutes.
So, just being very mindful of those calls, not sitting on scene in the back of the truck to do IVs and to do 6 different 12 leads and everything else. Go ahead and get en route. You can do all those things en route to the hospital.
Or put stuff in the computer.
Yeah, you don't need to worry about the computer because
Assuming them go.
on any call. Okay, you don't need your partner in the back putting stuff in the computer because how many times have you all seen a computer save someone's life?
Never.
How many times have you seen it assess a patient? How many times have you seen it treat a patient? None. Don't worry about it. Your most important thing is that you are taking care of your patient. Do not worry about that computer. You don't need to take it inside with you or anything else. You don't need your partner in there typing on it while you're trying to get all these things done. If your partner has time to be typing on the computer, then they should be up front driving to the hospital. And anybody who was ever on shift with me when I was on QRV, that's exactly what I would tell them. I'd check on them. Hey, you guys ready to go? Yeah, no. You got time to be typing, you got time to be driving. Okay. Suspected stroke scene time. So for this one, it's 15 minutes. Because we know that there's other things you need to do, checking sugars and things like that to rule out before we know for sure, okay, this is suspected stroke. So less than 15 minutes and less than 20. And we're doing really well on those. Our average scene time was 16 minutes and 23 seconds. Scene time for non-emergency transport, our goal is 20 minutes. And so we're doing really well with that. But if you notice, our average scene time was only 10 seconds more than that of our suspected stroke scene times. So that means we can do better with our suspected strokes, right? If we are doing that good with our non-emergency transports, okay? I'm still really happy with 1623, don't get me wrong. I'm really happy with that, but recognizing that we can improve a little bit, right? We're always gonna push ourselves to improve a little bit. Making sure we're verifying all information entered into ESO. Again, making sure our EMD codes are correct and our destination location is correct. Our EMD codes have been much better. I'm not having to correct near as many as I was. But destination location. So making sure if you guys are responding to the cottages at the VA and you're transporting to the VA hospital, you must go in and change your pickup location to nursing home, cottages at the VA. Okay, because it will automatically just comes up as the VA hospital from CAD. You have to go in and change it because what happens each time that's in there, it looks like we're transporting from the VA hospital to the VA hospital. And then every single one of those charts gets sent back to me from billing company for me to correct it. Okay, so I build it in there, so all you have to do is correct it, just choose nursing home and it's listed down in there. All procedures, interventions documented in your flow chart, right? Not just in your narrative, but they must be in the flow chart. If more than one patient's transported, one of however many, while we're transporting, all pertinent negatives and positives, and then why they're being transported from one facility to another. For all of your ketamine charts, make sure you're doing the appropriate ketamine forms. So your airway form is only for ketamine when given for airway. Your ketamine form is for ketamine given for pain and behavioral. Okay, so make sure you're using the right one. Make sure you're getting them signed at the hospital. Medication errors, ways to prevent this is going to be only to drop the amount of medication that you need to give. Make sure you use the correct size syringe needed, and make sure that we dilute it prior to placing ketamine in the bag if we're giving it for pain. Do not for any reason withhold treatment for a patient because you don't want to break the seals on your truck. Okay. Evidence in crime scenes. Don't remove anything from a crime scene or potential crime scene. Don't touch anything unless it's a safety concern and interferes with patient care. This includes suicide notes, weapons, drugs, paraphernalia, anything like that, right? We're going to leave it in place. We don't clear weapons. We don't do any of those things. I don't care how well you know it, how well you can do it. Let law enforcement clear the weapon. You can just put it somewhere safe if it's interfering or in your way. Once you leave the crime scene, do not re-enter unless approved by law enforcement. Don't go through their pockets looking for ID or anything like that. Don't go through cabinets looking for medications or anything. Let law enforcement deal with all of that. If they're DOA, we don't know the name, we don't care. Law enforcement will get that to us whenever they find it. And so that we'll have that information then. Okay. EMT trucks, if you are running an EMT truck, please do not tell dispatch that you cannot take the call that you've been dispatched to. All the EMD codes have been changed with Dr. Wells and Lee's approval as to what they can be sent to. So make sure if you are sent, you take the call. Some of them you will be sent to the call with a lead. If there's not a lead available and it requires a lead, then you will probably not be sent to the call. An ALS unit will be sent to the call instead. Make sure that you are logging in with an E after your unit number. If you're not an EMT truck, please do not log in with an E and then get to your zone and say, oops, it was an accident, and appropriately log in with your right unit number.
Wow.
Also, do not drive all the way to your zone and then put yourself in service. You are to put yourself in service at base before you leave. Do not drive all the way back to your zone from the hospital and then put yourself back in service. You're to put yourself in service and clear over the radio when you clear the hospital. Leads and supervisors, if they see that you're no longer at the hospital but still out of service, can tell Cumberland that you're back in service and have you put back in service. Okay? You're screwing your shift mates, so stop doing it.
Shouldn't be a problem with these guys, they know that, we've talked about it over and over.
We don't activate traumas based on mechanism, right? We go strictly by our criteria. So please don't activate based on mechanism. I know a lot of times you guys are getting to the hospital and the providers are upgrading it and they're activating based on mechanism. We don't do that. If they give you a really hard time, then you let us know and we will let Robin know and Robin will handle it, okay? But if they just hurt your feelings because you didn't like what they said, we don't need to hear about that, okay? But if they're rude, if they're inappropriate or anything like that, let us know, Robin will handle it, okay? You guys are doing the right thing because you are not activating based on mechanism. However, you get there and you get your butt chewed and you're like, well, did I do something wrong? And so the next time you go and you activate based on mechanism. And that's not right. We have a ton of overactivations just simply based on mechanism. And these patients are leaving the hospital within a couple hours. A fall from standing position is not a trauma unless the patient meets trauma criteria. Okay, so please don't make them traumas just because they fell. Hip fractures are not pelvic fractures. They do not need to be a trauma. Okay, and what was the other one?
Let's see if you have a question. Chuck, you have a question?
Yes, Chuck Arena.
Steel motorcycle going over the handlebars.
And ejection is a yellow, yes.
Non-ambulatory ejection.
Oh, is it non-ambulatory injection?
Non-ambulatory ejection.
Okay.
Um,
I know, one time it was both. That's why I was asking.
that's how it's worded, is non-ambulatory ejection.
Oh, okay. So if they go over and everything, if they get up walking around?
Away.
Yeah. Okay.
The fall from a standing position, so this comes from the ME side of things too. If somebody is standing up when they die, they're gonna fall, but it doesn't mean that fall killed them, right? So if you activate them as a trauma yellow, a trauma red because now you're working arrest, and you call it in as a fall, that follows them through the ME process, and they have to prove that this person didn't die from the fall you said they suffered. Okay, so make sure that if that is the case, that you choose your wording wisely when you're giving a report and when you're documenting in your chart. Okay, it's like Dr. Wells said earlier, if you find them dead in their car, but there's no damage to the car, they may not have died from a car accident, right? So same thing with the falls, just be very cautious about how you're wording and giving that report.
Makes sense.
To bring up crime scene stuff too, just be careful when you guys are doing your trauma assessment and cutting off clothes. Don't cut through holes or any kind of perforations in the outer clothing of the patient. And if you do, I still think we need to, or we are supposed to be putting them in the brown bag Bob has in the stock room.
Yes, there should be brown bags in the
You guys
truck
don't
and
know
you should
that
be
underneath
written.
where the ghost rat at the very bottom over on the side, on the right side next to the wall.
Yep.
We've had multiple complaints from the sheriff's office and policy about people cutting through clothes that's evidence, just kind of be cautious of it, and then, leaving it or throwing clothes away, which is evidence, and
And a lot of times you don't even need to cut the clothes off, right? You can pull a shirt up and look at things. You don't always have to cut the stuff off. The child restraints,
So we have heard that there are issues with child restraint systems. But when I say heard, I mean, we've had complaints that like people talk to each other, but nobody talks to us. And we cannot fix or get rid of or change anything that you guys have a problem with unless you actually tell us about the problem. So if you use not just the child restraint system, but any of the equipment and it doesn't work appropriately, it's not safe for the patient, whatever it might be, would you please send a message, like in writing, so that I have it, so we can do something about whatever it is, okay? This is particular to the restraint systems because Dr. Wells has had a hard time with them recently, and he has asked the nurses in the emergency room to do a SIR anytime that they see the child not properly restrained in them, and it's not on you guys, it's on the system itself, okay? So please let me know if that is not working appropriately.
PHTLS will be on November 30th and December 1st. I sent out the interest message, so we will be having it. You guys are off, so if you want to take the class, it'll be 8 to 5 at base. It is $15 for